Welcome everybody. I've got 1:59, so we're going to give it just a couple more minutes and then we'll get started. Thanks for being here today. If you're just joining us, we've got another couple of minutes and then we'll get started with today's webinar. Hello and welcome to today's webinar, Preventing Suicide Through Empowerment of Youth with Disabilities. Our presenters today are Ayers and Leah Smith. Dr. Ayers is the Associate Director and an Assistant Professor at the University of Cincinnati Center for Excellence in Developmental Disabilities. She is the Director of the Center for Dignity in Healthcare for People with Disabilities and a co-founder of the Disabled Parent Project. Leah Smith is a project coordinator for the Center for Dignity in Healthcare for People with Disabilities at the University of Cincinnati Center for Excellence in Developmental Disabilities. Leah managed the Live On anti-suicide campaign aimed specifically for people with disabilities and has served as the Director of Public Relations for Little People of America, spearheading many efforts to destigmatize dwarfism in media representation and empower little people in their everyday lives. My name is Kristen Dahl, and on behalf of the Mental Health and Developmental Disabilities National Training Center, I would like to thank you for taking the time to be here today. Please visit our social media and website, mhddcenter.org, for resources related to mental health and disability. We have a few housekeeping items to go over. If you are joining us on Zoom, the controls are located at the bottom bar of your Zoom window. Please use the chat box if you have any comments or technical issues, and we will do our best to assist you. Please use the Q&A to submit questions to the presenters. We will read your questions to the presenters during the designated Q&A time at the conclusion of the presentation. There is a hand-raising feature you can use if you need assistance from the MHDD team. Other than those presenting the webinar, everyone is muted and camera access is turned off. You do not need to be concerned with muting yourself or turning off your camera. This webinar is being live captioned. You can turn on captions in the Zoom window by clicking the CC button at the bottom of the menu or the More button and selecting Show Subtitles. You can also change the size of the caption text by selecting Subtitle Settings. We are having some technical difficulties with our live YouTube feed, so we will be recorded and put on YouTube in a few days. This webinar is being recorded and will be available on our YouTube channel and the MHDD website, mhddcenter.org. A PDF of the presentation slides will be available as well. We will be sending out a follow-up email after the webinar with an evaluation. We ask you to complete the evaluation so we can improve future webinars. The email will also include instructions on how to receive continuing education credits. If you are just joining us, welcome to the webinar, Preventing Suicide Through Empowerment of Youth with Disabilities. Thank you for being here, and now I'm going to turn it over to Dr. Ayers and Leah Smith.
Hi, everyone. Thank you so much for joining us. I'm going to share my screen. Give me just 1 second. So that you can see my PowerPoint. Let me put that in. All right. Thank you so much for being here. As Kristen said, my name is Leah Smith. Just a few disclosures. We have no potential conflicts of interest. We're both employees of Cincinnati Children's Hospital. Our affiliations have not unduly influenced this work, and we will be discussing suicidality throughout today's webinar. This topic may be difficult or triggering for some. So just as a little bit of an overview, today we plan to discuss the intersection of suicide and disability. This intersection is often overlooked and one that's not even researched to the extent of other marginalized communities. Kara and I are very interested in this conversation and how we can further it and continue the conversation about this. So this month, as many of you know, is Suicide Prevention Month. Last week included World Suicide Prevention Day. And in most states, suicide is the second leading cause of death for teens. In Ohio, it had risen by 56% over 10 years. So we're really interested in looking at the causes of this and specifically teens with disabilities. And so that's what we're going to be discussing today. So anytime we talk about being a teenager, you know, oftentimes we get a heavy sigh or eye roll. Like, all of us don't really want to go back to our teenage years. I think that's a universal feeling that, you know, that's a time that we're glad is over. Being a teenager is a tumultuous time for anyone, but adding a disability to that experience really complicates it a little further. All teenagers have that desire to fit in and be like everyone else. For teenagers with disabilities, it's a little harder because their bodies or their brains don't look like or respond in the same way as everyone else's. Bullying is very real. Dating is hard. Oftentimes dating is not even an opportunity for people with disabilities. Driving can look very different, whether they have to have hand controls or pedal extensions, or maybe they're not even able to drive. There's all kinds of complications around that. Obtaining their first job, a lot of teenagers are looking for the, you know, whether it's a summer job or a side job. I know as a disabled person myself, the first time I started looking for a job was one of the first times I'd experienced blatant discrimination. And that was a really hard thing for me to understand and think about as I was starting to enter adulthood, is what is that going to look like, and how am I going to do this, and how am I going to get a job, and if this is what I'm up against. You know, as a teenager, all of these things feel much bigger, and not knowing how to overcome them. Again, with that, obtaining the first job, figuring out college and career plans, again, very difficult it adds a complication to the experience. And then also the impending separation from parents or caregivers. So oftentimes as disabled children, our parents have kind of figured out what our needs are and have accommodated for us. And so that impending separation of what is it going to look like when mom's not doing my laundry for me? Am I able to do that myself? Will I be able to find another way of doing it? And oftentimes the mom is just, or the dad or the caregiver has just perception and achievement, and higher rates of social rejection, loneliness, and stigmatization. And if you know anything about suicidality, you know that all of these things are risk factors for suicide attempts. So when you add all of these together, you're realizing there's a bigger picture here of what's going on with youth with disabilities. Shows us that people with disabilities experience depression and or suicidal ideation, not because of their disability, but because of social factors such as stigma and ableism. A lot of us know that term stigma, but let's first define that ableism word. Some of you may have heard it, but not everyone. So ableism is discrimination in favor of able-bodied people. It's often rooted in a medical model of needing to be fixed or cured. And then with that is structural ableism. And those are, ableism is usually by people. Structural ableism is more systemic, and that there are barriers that deny people with disabilities access, such as stairs or no elevators, no push buttons for doors, lack of ASL interpreters. Those kind of things are all structural ableism, and the list could go on and on. Those are just a few examples. So let's go back to that. Research shows us that people with disabilities experience depression and or suicidal ideation, not because of their disability, but because of social factors with that discrimination. So research has shown with people that acquire disabilities that they're able to adapt to learning how to use a wheelchair, for example, or a cane, or whatever the disability requires. Those things we have systemic things in place, like different types of services for them to learn how to use those. But what they don't have resources on is how to deal with suddenly they are experiencing discrimination from their family members. Suddenly they're experiencing discrimination from their jobs after acquiring a disability. And this is no different for youth with disabilities as they start to become their own person. So among youth with disabilities, simply verbalizing at school or in front of their peers that they have a disability increases this risk of a suicide attempt. So this goes further into the stigma aspect of it. How much stigma is associated with disability? Youth with learning disabilities are often concerned with performance and keeping their challenges a secret. They don't want other people to know because they don't want to be stigmatized. And stigma is often moderated by parents and teachers, which portray lower expectations because of the disability. There's often almost an infantilizing tone that comes with when teachers or parents are talking to them or even about their disability. And that kids definitely used to pick up on that. So let's get into the meat of this. What does this actually mean for youth with disabilities? What it means is that they're 3 to 9 times more likely to experience suicidal ideation compared to their non-disabled counterparts. 3 to 9 times is quite a bit when you look at that other statistics that I mentioned at the beginning of where Ohio is, I forget the exact statistic, I think it was 56%, it has risen. So this statistic is really alarming when you start looking at people with disabilities. So research shows that this increased risk is directly linked with the experience of structural ableism that creates economic and bureaucratic barriers for people with disabilities. So what are some of those structural ableism that we talked about a while ago? That's a lack of physical access, communication access, access to appropriate education, access to community-based long-term care supports, assistive technology, transportation, employment. These are all things that youth with disabilities are realizing, and realizing that they have a lack of access to, and that there's that it's a bigger world around them that is not accommodating their needs. They often just don't have the language to explain that. Let me stop sharing and show this video. This is Joe Stromando sharing his experience with structural ableism.
Hi everyone, my name is Joseph Stromando, and I am an assistant professor of philosophy here at San Diego State University. And I just wanted to say a couple words about ableism in higher education. I think that there's a variety of ways that structural ableism can definitely make things really difficult for people. Just obvious examples in my life that come to mind immediately had to do with being an undergrad, especially where I went.
Hi everyone, I apologize. I realized that some of you were not able to hear that. So let me try again with that.
Leah, when you click share screen, bottom left of that window, share computer audio, check that box.
Perfect. I'm going to start that over for everyone. Yeah. Okay, I'm going to start over.
Hi everyone, my name is Joseph Stramondo, and I am an assistant professor of philosophy here at San Diego State University. And I just wanted to say a couple words about ableism and higher education. I think that there's, a variety of ways that structural ableism can definitely make things really difficult for people. Just obvious examples through my life that come to mind immediately had to do with being an undergrad, especially, where I went to a very old private college that had lots and lots of stairs. And so what was odd about this is that the dean of students was the person charged with dealing with disability accommodations, had an office that was up 2 flights of stairs. So it was that kind of irony, right? And it wasn't just the dean of students. Most of my professors were in a building that had stairs, and so I very rarely saw the inside of any of my professors' offices. And so it was that kind of thing that just sort of meant that there wasn't really an equal playing field. There was a lot more that I had to do than your average person attending school, because I had to sort of think things through and put all of the effort into figuring out, okay, well, I can't drop into my professor's office hours like most people, and so what am I going to do? I have to figure out a way to schedule a meeting with them and explain that I can't get to their office, and so on and so forth. And so that's just sort of an added task when you're already very busy in school. Sort of having that extra layer of work is something that puts you at a disadvantage, and that's a very real disadvantage. Just briefly in closing, I want to say, even in places where they have a really well-organized effort for making accommodations for disabled students, a lot of times, unfortunately, the orientation toward those accommodations can be one of just sort of trying to avoid lawsuits, trying to avoid litigation, doing the bare minimum that's required by the law, instead of seeing an accommodation as something that you need to do in order to help this student have equality and flourish. Unfortunately, a lot of times accommodations are seen as, well, what can we do to make sure that this student doesn't, bring an ADA lawsuit against us? And so the problem with that orientation is that it ends up being sort of almost like an adversarial relationship from the get-go. And that's really difficult for a student who's trying to go to school and just wants to be able to get their degree, to have to fight every step of the way to get what they need in order to thrive. And so I just wanted to acknowledge that. Like, I've experienced some of that myself. I've seen it with, some of my own students. And so, I just think that it's important that faculty and staff that have been through this sort of recognize that it's a thing. And so that's what I wanted to talk about today. Thanks.
Oh.
Hi, everyone. My name.
All right, so that was Joe Stramondo sharing his experience. I think he mentioned he's a professor at SDSU, and that was his experience as a student. Let me see here. Share this PowerPoint again with all of you. So that video that you just saw was a part of the Live On campaign, which is an anti-suicide campaign aimed specifically towards people with disabilities. As part of the campaign, there's video testimonials about struggling with ableism. The testimonials, the topics range from ableism in higher ed, as Joe talked about, advice that they wish they could give their younger disabled selves, and debunking myths about disability are all issues that they talk about. There's also blogs on the website. There's resources for people with disabilities. There's a whole list, alphabetical list of centers for independent living across the country that they can reach out to. That's a great resource for youth with disabilities. There's toolkits for both higher ed and centers for independent living about how they could use this campaign in their own organizations. And then there's the Dear Disabled and Proud campaign, which was a really interesting campaign that we did, where people wrote in. It was kind of a Dear Abby style. I don't know how many of you know about Dear Abby. I think it was back in the 80s, maybe, I don't know, but people wrote in. I think at the time it was for newspapers, so now updating it a little, it was an online campaign, and people wrote in and asked how they could become more proud disabled people. And the topics on that ranged everything from media representation and how much that helped, to move for the first time and what does that look like and how do you do it, and adapting without having your parents, how to combat internalized ableism, and labeling yourself as disabled. A lot of times messages say we should not be labeling ourselves as a person with a disability. And so the letters often that were written in were asking, what does it mean if I did do that? And I'm seeing a lot of people that do that as proud disabled people. So how do I cross that barrier? What really was interesting about that campaign that turned out was that people ended up sending pictures of themselves and what they felt like were their proud disabled moments of maybe they were at a concert, but they were using their wheelchair, and that seemed like a big deal to them because they weren't always out about using their wheelchair or a cane, or maybe they had a shirt that said some proud disabled person, and but it was all these pictures that started emerging of just disabled people coming out basically and saying I'm proud. And I thought that was a really interesting result of that campaign that we weren't expecting. Secondly, is the My Ableist Therapist. Something that Kara and I both have experienced when we talk about suicidality among people with disabilities is this common response we receive when discussing disability and depression and suicidal ideation. It's how to find a therapist. A lot of times, I can't tell you how many times someone in the audience has raised their hand and said, yes, I've experienced all of these things. I understand ableism, but I can't find a therapist. When I reach out to a therapist, I'll call and ask them, are you accessible? And they'll arrive to a flight of stairs. Or even if they don't have any stairs, they'll get there and be told something along the lines of course you're suicidal, you're disabled, or other ableist advice from their therapist. And so there really was, out of this came a real need for how do I find an anti-ableist therapist. Here is some of so we ended up having a Twitter chat about #MyAbleistTherapist. Some of the conversation around that, here's a few of them. I was going through a really rough time a few years ago. My boss made fun of self-care, so it took a lot of time for me to finally call the Employee Assistance Program. EAP referred me to a local therapist, and when I arrived, I saw her office was up a flight of stairs. I called to ask if she had an alternative entrance or could meet elsewhere. She said this was my fault because I should have told her I used a wheelchair when I made the appointment. I told her the ADA had been around for over 25 years, so her office should be accessible. I then sat in my car crying. It took so much for me to finally reach out for help, and when I did, I was met with ableism by both this therapist and the company's EAP. I didn't reach out for help again for 2 years because I didn't want to deal with the ableism. Another conversation, someone posted, during my third round of voluntary partial hospitalization for depression, my therapist told me that I was trying to live my life like a non-disabled person, but I was severely disabled. Not to worry, she said, I could always be on Medicare and live in a group home. So these are all experiences people have had. You can check out my ableist therapist for that conversation, hashtag my ableist therapist for more of that conversation. It's really interesting to see what people have experienced in therapy. So as I said, I managed this campaign, and one of the things that I really learned from it was the power of community and how important that is. I was lucky to be raised in an organization for disabled people, and I never fully realized how much that helped with my own mental health. But what I found from the Live On campaign is that people with disabilities are so thirsty for this, and they really are just want to hear how other people are dealing with these things. And it's a conversation that's really hard to have sometimes, even in person, of how do you deal with ableism. But it really develops that sense of self-worth in an ableist society, and it really validates their experience that they, you know, a lot of times we experience these things and are told, no, that's not what they meant, or that's not true, or whatever. You know, I think the other really neat thing about this campaign is, you know, obviously people with disabilities are not just in one area, but they're across the world. This campaign had followers from across the United States, Europe, and New Zealand. And it was really interesting to see how they were all talking about the exact same thing. And they were all really interested in the same topic, no matter where they were. But this sense of community really seemed to be like it allowed them a space to talk about it, but also it seemed to, we got comments such as, I like this campaign because I need reminding almost daily that I'm not inferior, that social message that people with disabilities receive is so strong that it was that powerful for them. And then another comment was, reading this, I realized I have some work to do accepting and loving my disabled self. So I think that really spoke to the power of it. You can check out Live On. It is unfortunately no longer funded, but it is still on the internet, liveon.net, and is still, you can still see the videos and that kind of thing. As far as I know, it was, or at least as of yesterday it was. So I can't tell you how long it'll be there, but I think it is a great resource for, and I think this really shows how important this work is still needed. And I will let Kara take it away from here as far as going, what we want to do from here and how other ways that we can help.
Thank you so much, Leah. All right, so I'm going to jump in and share that kind of, I bring a few different parts of my background to this. So I'm trained as a clinical psychologist, and some of my clinical training also involved work, it focused on work with youth, and including some work in inpatient psych facilities where I did see youth in crisis stages who had attempted suicide or who had suicidal ideation. But fast forward from that work into my USAID career, where I no longer see patients or work in a clinical way at all. I now look more so at inequities among my tasks at our Cincinnati USAID. I look at inequities in healthcare treatment of people with disabilities. So when we try to zone in on this, we really try to think of what are the worse outcomes or inequitable outcomes that are a direct result of disability discrimination. So that is the focus that I wanted to look deeper at, related to the treatment of suicidality among people with disabilities, and also specifically among youth. So to get us started, I have this illustration that shows, oh, let's see, I have a message. The host asked me to start my video. I'm going to put later, I guess. Okay, sorry. There we go. Sorry. All right, so thank you. This, hopefully you can see this hospital illustration. So it's got 3 paths, and this is the first instance of inequitable treatment that many youth with disabilities experience when they seek treatment. So you've got one path that's a very straight pink line into the healthcare system, one that's got a few curves, and one that's pretty convoluted and has lots of starts and stops. And that's what Leah referenced related to finding out that offices aren't accessible, when you finally find one that's accessible, and not only in a physical sense accessible. Maybe you find a therapist that says they have experience working with someone with an intellectual disability, but when you get in, and this is the case for any therapeutic relationship, it may not be a good fit. But for people with disabilities, we just have fewer choices in the first place that kind of meet those basic accessibility needs. So those poor fits are even more problematic in our journey to get care. So I wanted to share a very recent study just out this month, actually, by Emily Lund and others. This is a 2020 study. And this looked at, it was a survey of 500 Americans, and it was an online survey. So it was kind of a generalized population. And it looked at whether these individuals thought that they saw suicide as acceptable. So they were presented some vignettes, and across the vignettes, they had some pretty typical youth-related issues, things like relationships ending, hard transitions, difficult finding first jobs, those types of things. And so what they found was that if the vignette included mention that the individual in the vignette described had a disability, that most participants thought that suicide was more acceptable for that individual based on disability alone. And what I think was most concerning to me about this study, unfortunately, I wasn't so surprised to see that people seem to find higher rates of acceptability in suicidal thoughts if a person had a disability. But more so, what was surprising was that this held true even when that person had a family member or a friend with a disability. And the reason that I found that surprising was that in much of the work around implicit bias and our attitudes towards disability, one of the ways that we address that and try to make things less biased, or first of all, uncover bias, because we know that if we can make it explicit, that's the first kind of opportunity we have to talk about it, reflect on it, and address it. But one of the ways that we do this is to try to connect and see if an individual has a family member or friend with a disability, or if not, things like panels of people with lived experience with disability can help break down those implicit biases. So I found that that was concerning, in that even though some of these people had those connections that we know can be a protective factor against those biases about disability, they still had higher rates of acceptability of suicide. And so I hope you can see how that would put another kind of barrier in place in terms of seeking treatment, not only on the provider side, but on friends that a youth with a disability might approach if they're having these thoughts, or on family members. If there's a greater kind of acceptability of this in terms of kind of it being an understandable course of action to end one's life based on disability, then treatment can be that much harder to secure for youth with disabilities. Other inequities in treatment that we found as we looked further into this, one of the most concerning ones is this challenging and complex question of where treatment should be administered in the case of someone who's acutely suicidal. So a youth who not only is having suicidal ideations, but has a real plan, may have already attempted, and is at immediate danger of harming themselves. So in most cases, if that were the case for a non-disabled youth, inpatient short-term psychiatric stay would be a course of action that many providers would recommend. But in the case of youth with disabilities, they're often denied this admission, even if it's something that their family, themselves, or their provider recommend, due to concerns for the safety of others in the unit. And I've seen this happen with youth who have had used crutches for mobility, youth that have had insulin pumps related to their diabetes. So both of those pieces of medical equipment have been cited as safety risks in the unit. And in both those examples, neither of those individuals had any history of aggressive behavior with those pieces of equipment. So there wasn't any type of documented concern with that. It's this hypothetical concern that a wheelchair cannot be in this environment or crutches cannot be in the psych unit environment. And the problem with that is the youth with a disability misses out on the MALU treatment, the intensive daily therapeutic opportunities that are offered in both a peer group format and also individual therapy. So sometimes youth with disabilities are placed on a medical floor instead of a psych unit. Again, the treatment is not the same, separate, not equal. And sometimes, many times, they're discharged and told to follow up outpatient. And you can see the risk of that if someone is just acutely suicidal at that moment. And I mentioned that this is complicated and it's so individually dependent in terms of what's best for each patient, because it's also really important to note that involuntary hospitalization brings with it its own set of potential harms for people with disabilities. And some of that is tied to the history of institutionalization and just concerning and abusive treatment that our disabled community has experienced over the decades. So for some people, the goal is not inpatient treatment, and because of disability, that should be a consideration as well. It is worth noting, though, that when you look over the research of what patients reflect on related to their psychiatric hospitalizations, the majority of which, close to 70%, after they've completed their hospitalization, look back on that as an experience that they found helpful, satisfactory, and needed at the time. So, of course, it can be a very uncertain, scary time. It often happens without warning. And so that would be terrible for any of us to learn that, effective immediately, we're going to be in a hospital for a few days. So when we ask people acutely or when they're in the hospital, there's a lot of variance in how they feel about getting that treatment at that time. But after the fact, young adults often reflect that this was an important turning point for them, especially if they received high quality care, which is always a factor. So another piece that we've noticed is that in medical protocols and guidelines that help professionals decide best practices or help professionals identify best practices related to the treatment of suicidality, disability is almost never mentioned, period. But when it is mentioned, it's mentioned in a very medical sense. So things like chronic pain are noted, but not other disabilities like intellectual disabilities, and definitely not social aspects of disability. As Leah mentioned, the structural ableism piece is often definitely a corresponding factor to the situation at hand, but it's not brought into play in many of these medical guidelines. And Up to Date is one of the most used platforms for these medical protocols. So I've linked the suicide protocols through Up to Date so you can get an example of that. And I did see a question popping up in the chat while Leah was speaking. You'll be, when you access the PDF of these slides, you'll also have all the links. So you'll be able to get those for reference if you'd like to. So Leah and I worked together on the project that was noted in our intros, the Center for Dignity in Healthcare for People with Disabilities. And again, this work really hones in on those life-limiting healthcare inequities that are based on disability bias. So at this point, this topic, suicidality and mental health, is one of 4 subcommittees that the group works on. And this subcommittee, the Mental Health Subcommittee, has just completed gathering resources for a gap analysis to determine what's out there, what policies are related, what are best practices. So we really looked all over the place, from blogs of youth with disabilities who have shared about their treatment experience to peer-reviewed articles to policy pieces. So it's over 200 resources over all the topics. And this one was a tough one for us to really dig in and research on, because as Leah noted, there's not enough focus on this field or this area of multiple fields. So not in the disability field, not in the mental health field. Even among suicidologists, I had reached out to some via Twitter who studied just suicide with their careers. And I tried to see if any had specific knowledge related to disability and suicide. And so I contacted 3, and none of which, all 3 said, oh, that would be really important and more people should do that. But none had specific knowledge. Despite their interest in work in other marginalized populations, disability had not yet come up in their work. So as Leah noted, one of our hopes for this next year too is to outline how to find an anti-ableist therapist. So just based on the frequency that we encounter this challenge, we feel like that is an important resource to explore in terms of what questions could an individual or their family members ask to not only find out if it is accessible related to disability related needs, but attitude about disability is important in therapy too. So finding that fit. So that leads us into another product that Leah and I have developed in the last few months to start to address what we saw as this gap related to youth with disabilities and suicide. So we were contacted in Maryland by the Accessible Resources for Independence, SIL, and we were excited to have the opportunity to explore what would a curriculum look like for youth with disabilities to address suicide. And so we developed the Undoing Ableism Suicide Prevention Curriculum. And our goal was really to empower the youth with knowledge related to depression and suicidality, to challenge them to counter ableism with some strategies that we practice during the workshop, and to include making, in this curriculum, we included making intentional connections with the disability community. So the curriculum itself is intended for in-person delivery, which we know is a little challenging at this time, which is also why we're not sure when it will be facilitated for the first time and then after that perhaps available for others. So we are kind of hoping, so it's up to the SIL for delivery decisions, but I hope in some way that in-person delivery is possible because it would allow that connection to also be a part of the curriculum. As you know, we can also do that through Zoom, but it's a little bit harder, especially I think for youth in some ways. So it's intended to be delivered over 4 hours, and it covers the following things. So first, with the youth, we look at warning signs for depression and suicide. We talk a bit about how those two things are not the same all the time. We also talk a bit about how self-harm is also not the same. So that moves us into dispelling some myths about youth suicide. And this is a common component of many youth suicide curriculums, youth suicide prevention curriculums, but our portion of this has a little disability spin in terms of what people think they know about suicide risk factors and how you should approach a peer or a friend who may be expressing suicidal ideation. We talk about some protective factors and coping skills, but more importantly, we practice some as well in session in hopes that those carry on after the fact. And this is all based on the idea of trying to establish and build a foundation for disability identity and eventually, hopefully, pride, as we know that's also a protective factor against ableism. So really looking at this as an empowerment tool is behind a lot of what we included in that identity piece. So there are some didactic portions of the curriculum, but we knew we were dealing with youth and they didn't want to hear us talk the whole time. So there are also some short video portions like the Live On videos that Leah referenced. There's some opportunities for the teens to have facilitated discussions. And there's also some guided journal activities that we also have a hashtag component piece that they could carry some of these conversations, the not so personal ones, but more the group ones in a social media setting. And that brings us to one of our example videos that I wanted to share that's built into the curriculum. This is Alice Wong, and she speaks a bit on internalized ableism and how she coped with this as a youth. So let me share the screen.
Hi, my name is Alice Wong. I'm 42, and I have a neuromuscular disability called spinal muscular atrophy. I use a wheelchair, a BiPAP machine, oxygen in a hospital bed at night, Medicaid personal assistance services, and a whole lot of help and social support for family and friends. In the last few years, I've gone through a significant progression with my disability. I used to use BiPAP only at night to prevent sleep apnea. but started to use it gradually more through the day. I now use it almost all the time during the day. I had to get used to my voice. It sounded different. I see other people struggle to understand me when I talk. As with most of my experiences growing up as a disabled person, it's been an exercise in confronting my internalized ableism and being worried about how others perceive me. Some folks might see me and feel sorry for me, that being attached to a tube or a machine is not a life worth living. I want people like myself to live on. This year has been really rough with two very high-profile cases of young people with neuromuscular disabilities wanting to end their lives and ultimately doing so. Then I get it. The feelings of frustration, loss of control, and overall pain and discomfort that comes from a disabled body. My concern is whether disabled people have the access and privilege to explore every possibility in pain management, mental health, and community sports before wanting to end their lives. The struggle is totally real, and yet I want to live on because the migrant body is an amazing work of art. It's shaped by the elements, like a piece of gnarly driftwood. With all the pain, the depression, the day-to-day shitty realities of being disabled in a non-disabled world, there's a lot of beauty and creativity and wisdom that emerges from my crip body. And it's not just about our bodies. The drive to live on is for our survival and the communities and relationships around us. So, I'm gonna live on as hard as I can while keeping it 100% real. There is a lot of collective wisdom from disabled people out there that can help you live on as well.
Okay. All right, and I'm actually going to move, since I've still got the right screen shared, I hope, I'm going to move into this. There we go. I can blame my kids for various Minecraft videos that pop up after everything I show. All right, so this is one other very short video, less than a minute, that includes a perspective about how this young adult found the disability community.
Hi, my name is Tings Floyd. I was born with my disability, and I was not involved with the disability community until I was 15 or 16 years old. It was only because Colleen Flanagan met me at an event that I actually became engaged with the community. And if there was one piece of advice that I would give my younger self, it would be the disability community, or the disco, is a very safe space. And I use that term non-ironically because the more I learned to engage with the disability community, the more I learned to engage with the community in general, and the more comfortable I felt engaging with everyone. It matters, the representation of who you have around you, and it can change the dynamic of how you see yourself.
Okay, so as, there we go, thank you. Let me switch to my other screen. There we go. So as noted, those videos are kind of opportunities for the youth to see other youth with disabilities, and this curriculum is designed to be led by a disabled leader as well. So I think that helps kind of address the question of, well, if connecting to the disability community is important, how do you get that started? And we've also referenced that, you know, SILs and USEDS and other, we realize that this is a local and a regional challenge as well for some people to figure out how best to get connected to other youth with disabilities in a way that works for them. So let me get us back to the, sorry, I lost my window here. There we go. And I noticed in the chat box a couple of questions about the videos. So these are linked on YouTube. And if you want to go back and use those for trainees to share, you can as well. So those will be on the PDFs that you'll have access to. So a few notes on conclusions that we've come to as we've kind of explored this area further. And as I hope I've made clear too, this is, you know, relatively new for me in terms of pulling these things together. So I came at this from a general psych perspective, and then I kind of paused that and really focused in on the disability world and Leah's work as well, kind of our opportunity to pair up. So we're still learning and exploring, and I'm happy to connect with any of you that have pieces to share that we could build into this as well. So this is kind of the beginning of our journey, definitely not the end, but we are recognizing that it's an important path to pursue. So just in conclusion, recognizing that the role of stigma and ableism must be addressed when you're treating depressed youth, youth with disabilities, that those pieces can't be overlooked or seen as kind of background or sideline pieces, even if the youth and or their family members don't necessarily have the words to label them in that way. Hopefully you can help identify what pieces might be contributing related to stigma and ableism. Accessibility and equity of treatment must be improved. And this, hopefully we all feel some pieces of accountability in this related to whatever systems that we're involved in. So even if your clinic has not yet had a youth with disability that has sought services, you know, it's still, again, 30 years with the ADA, it's still all of our obligation to ensure that when and if that first youth appears, that the clinic is accessible, and not only in a physical sense, but also for youth with intellectual disabilities or for other developmental disabilities, where the way treatment is administered or screenings for suicidality are administered is accessible. And a quick note on that, you know, that's another area that our Center for Dignity is currently exploring, is one of the most common screeners for suicidality used in hospital systems is not accessible. So we have been in touch with the developer of the of that screening, the Columbia screening tool, and they are open to an alternative version that would be lower reading level and would just be more clear in its language. And so we're hoping that, you know, chipping away at these barriers can help open the doors so that youth with disabilities can get the equitable treatment that they need and deserve. So I think we are happy to take some questions and eager to hear your thoughts and questions around this. I saw a couple in the chat box already, but just before that, I wanted to mention that these slides also have our references on them if you want to check those out. And then last, they have our contact information too. And Leah and I are happy to, we can drop our emails in the chat box as well, so you have those even before you get these slides. But we hope that you will get in touch if you have questions or comments even after this. And additionally, we hope that you will connect with us on social media channels. So we have our general USED pages here, which will always share this type of work there, but we're also really excited that within the next couple of weeks we'll be officially launching, they're already up so you could already like them, but we'll officially be launching our Think Equitable platforms, and that's connected to our Center for Dignity. So we hope you'll connect there so that you can keep in touch with this work and see how it progresses and grows, and we would love to hear from you now with questions.
If you want to put your questions in the Q&A box, and I will ask them for you. So the first question is, what is the age range for the youth for the curriculum?
Yeah, I think we specified 13 to 21, didn't we, Leah? Or 13 to 18.
Yeah, 13 to 18, I think, was what we said. It's a pretty broad, yeah.
I think we did stop it before the transition to college because we felt like that brought, or transition post high school for many people, we felt like that brought some additional and unique challenges. And there is a piece in the curriculum that deals with ableism related to assumptions about sexuality. So we didn't go younger because of that. It doesn't go into great detail with that. It just talks about what it's like to be a young person and for much of society to assume that one is asexual. So we do have that component in there.
What are some small examples of what anti-ableist therapists have done well that helps clients feel welcomed, comfortable, and safe during the first session?
That's a great question. I think that acknowledging the disability, I've heard people say, even just saying, so, how do you feel about your disability? That's going to really have a broad range of responses depending on the person. So just recognizing that it's a thing, but also even asking, is there anything that I can do to make my office more accessible for you? Is there anything you need? Those kind of questions are really helpful. Are there any others that you've heard of, Kara?
I think that it is important, the recognition, it seems to fall in line with some of the work that we see related to how, well, people are well-intentioned when they embrace like a colorblind approach. That's really not helpful. And similarly, I think that if people completely ignore the disability, then that can feel like a piece of a person is being ignored. And that's not to say that everyone comes with a disability positive identity to therapy. So maybe they want to talk about what are the rough parts of disability, but I think finding that balance between recognizing it and acknowledging it, and also just thinking about different formats of therapy. I know that it's somewhat common for many therapists to recommend resources like websites or books, and just thinking about kind of helping with some of the labor to access those tools in an accessible format. So if you typically hand, I know that when there were new diagnoses made for kids with ADHD in previous clinics I've been in, there was kind of like a typical handout that we gave parents that had links and some books. Well, recognizing that if an individual is blind or needs other formats for this type of materials, not just handing that list and kind of passing it out the door, but doing some of the labor with them, alongside them, to access what they need to benefit from therapy in accessible forms would be important too.
But I think also understanding that, a person's disability isn't their whole life. So I think it's kind of a fine balance of, just because they're there doesn't mean that they're there to fully discuss their disability, and that they have other aspects of their life as well that may or may not be influenced by their disability.
Yeah, and I think I just last on the end of the client with a disability, some of the work that I've done too is I think when we're used to seeking out medical treatment, we look for a provider that has a specialty in our specific diagnosis or disability. And when you're seeking a mental health provider, that can look a little different. So for my disability, osteogenesis imperfecta, it's a rare condition. And so some of those in my community have said, well, I've tried to find a therapist that has experience with OI. And your odds of finding that are going to be so low. So you don't really need a therapist that maybe has even heard of your specific type of disability. And I know there are exceptions to this, but I'm saying you more so need an attitude of openness, someone who, is willing to learn, but really looks at it more from a diversity and a social lens perspective, than you need someone who necessarily knows what especially if you have a rare condition is.
Did length of disability make a difference for those with suicidal ideologies, from birth versus recently acquired?
I don't know if there has been an in-depth study. I have read some research about newly acquired spinal cord injuries and suicidal ideation related to that, and the finding of that bring real concern to some of the very complicated assisted suicide debates in the disability community, because as people get further out from their injury and adapt to disability more, their suicidality or their suicidal ideation in general decreases. I haven't looked at this research recent enough to make solid summary of it, but it brings to light that, and it makes sense that in acute injury phase, right after you learn that you're paralyzed, you may be more likely to have thoughts about questioning continuing to live in this way. But I think one thing that stands out to me is super interesting in the way that our society treats developmental disabilities versus acquired is those that acquire an injury go through all this kind of social training with their wheelchair. So I've always been fascinated that like the rehab for a 17-year-old that acquires a spinal cord injury includes things like learning to get on a bus with your wheelchair, learning to go up a curb cut if you need to and the place is inaccessible. And really our healthcare systems, most of them for kids with developmental disabilities who are born with their disability and need a wheelchair, they don't ever have that kind of like social integration training. It's not built into our regular, you might have an innovative physical therapist or occupational therapist that does that, which is great, but it's not built into our regular treatment programs like it is for somebody who acquires. So I've always found that interesting in the way that our society kind of realizes the importance of integration with a disability in a different way if it's acquired than a developmental disability.
Our time is at an end. I've got a couple more questions if you guys want to stay after, and if any participants want to stay after. So I want to thank you, Kara and Leah, for being here today, and thank you for attending today's webinar. We'd like to make you aware of our next webinar, which will be held Tuesday, November 10th from 2 to 3 p.m. Eastern Time. Our presenter will be Justice Shorter, who will be presenting Centering Individuals with Intellectual and Developmental Disabilities During Crises and Emergencies, which will identify advocacy strategies and address how information and inclusion can reduce harm, save lives, and preserve personal equipment and property. We will put the link in the chat for the registration. And then if you guys want to stay on, we can ask a couple more questions. Kara and Leah, if you've got time to stay.
Yeah, sure.
Yeah.
Thank you all for attending.
Yeah.
Okay, so one of the questions, my concern is that I work for a residential facility that has a special unit for children with neuro and has suicidal issues as well, but the staff are not trained at our facility. Do you have training resources that you would suggest for their staff?
I think I would wonder, and I don't know if the participants can't unmute, can they? Because there's too many. That would probably be a disaster. I guess I would wonder which side Tammy felt like that more training was needed on. Was it more related to the disability side? That's what I would guess based on her question. And I don't off the top of mind have specific resources for staff training, but I always think it's helpful to connect with, kind of mentors in other similar facilities or organizations that are already doing this work. And that might be helpful. Leah, do you have anything else?
I don't.
Okay, thanks. And if you're still there, Tammy, you can put it in the chat and we can specify. Yeah. Okay, from the 2020 study that you referenced, was there a distinction in the study between respondents' empathy related to thoughts of suicide versus thinking that suicide is appropriate?
The way that I interpreted it, it was not so much putting them, it wasn't so much empathy, it was more, well, I guess it depends on how you define empathy. So I don't think that this study dug deep enough to determine whether that the people who had concluded that suicidality was acceptable was based on that they were putting themselves in that person's shoes. So I think it's important to know that the vignettes were not super detailed and that the individuals in the vignettes didn't have what most of us would consider to be extremely significant or severe disabilities. So I don't know. I think it would be too much of a leap for me to determine that people thought it was more acceptable because they were thinking about what it would be like for them to be in that person's shoes. It seemed like it was more so like they were thinking about what it would be like to be that person, I guess.
Okay, we have two more questions. How can individuals advocate for providers who are bilingual, ASL and Spanish, with their insurance providers that push for interpreters rather than out-of-network providers who can meet the language and cultural needs?
I'm not
Wow.
familiar with that.
That would be so much better though, to
Right.
have, you know, a bilingual provider. I think if you could, and I haven't specifically looked into this literature, but it's super interesting, so I will after this. But I mean, we all know the battles of insurance companies, but I mean, I think that you could show that anytime that you involve the additional component of the interpreter, there's a possibility of things to be lost in translation. And if you had a one person for that, you would minimize that risk so you could maximize your therapeutic benefits. So I think you could put together like a well-worded case for it, because it would undoubtedly be better. I don't know. I don't have experience knowing how the insurance companies would respond or not, but it would definitely be something worth advocating for, or at least trying.
Okay, and does the program discuss comorbid physical and emotional disabilities?
Are you talking about the Live On or the curriculum?
I'm not sure.
Okay.
I think they both do.
Yeah.
Live
So
On
I guess the
definitely
answer-
does.
yeah.
Yeah.
So I guess the answer is both, yes.
Okay.
Yeah, we took a very cross-disability approach because, I mean, structural ableism, while it impacts people with different disabilities differently, it's across the board no matter what your disability is. So it's across disability.
Right. I think one of the shortfalls of the Live On campaign is it's really who submitted videos, right? So self-selection, and getting that cross disability aspect of it was a really hard aspect of it. As the project manager of that, not everyone wanted to be that public about their mental health. One of the biggest things I learned from that project was I would reach out to disabled leaders and I would say, you know, will you do a video? And I was amazed at how many times I was told, I don't know how to deal with my own internalized ableism yet. When I figure that out, I'll do a video. And I think that just goes to show more of the problem. But to answer your question, I think that Live On is probably more limited in that aspect, though we definitely tried.
Yeah, and we don't know who will, you know, sign up for the first round of the curriculum. We hope it's cross disability, but I think it's hard to say.
Okay, a couple more have come in. Would you guys like to keep going?
Yeah, sure.
Okay, how can crisis hotlines, National Suicide Prevention Hotline, Lifeline, better serve callers referrals from youth with disabilities?
This is a really interesting question. When I was setting up Live On, I reached out to all of the hotlines to see which one was the best fit for us, and we ended up going with the crisis text line because it was the most accessible across disabilities. However, when I talked to all of them and I asked them, you know, if a caller with a disability said, you know, that they had a disability and that this was part of their part of the problem for them, what would the response be? And every single one of them told me that they did not have any disability specific training. So I think that this is something, another area that would be really important for people to, or for someone to train on. Maybe Kara and I'll take that up one day, but I think that that's a really important aspect of this. They noted that they do have training on other marginalized communities that they would try to, you know, cross over on the training. But I think that it's, and while that would be helpful, I think that there is some crossover between different marginalizations. I think that a disability-specific training would be really important for these hotlines.
Yeah, I agree.
Great.
I saw a question that was on but disappeared about CEUs for mental health professionals. And that's something I pretty consistently work on in coordination with the American Psychological Association. There is some work within that organization related to specifically disability cultural competence, but you know, it varies. There's different workshops for different programs. So I would need to know more about what the person was looking for, but there are some available.
Okay, as I said, I would follow up on that one too. So maybe
Yeah.
we can send
We can work
a
together.
joint. That would be great.
Mm-hmm.
Okay, so last question. Can you talk a little about working folks who in medical parlance are nonverbal and don't or can't use communication devices. How do mental health professionals assess for suicidality and other mental health needs in this case?
It's a great point that has also come up in our subcommittee and really was in some ways the start of our conversation about what are the problems and what's missing with the currently available screening tools for suicide. And that was definitely flagged as a huge challenge in terms of that the screening tools are almost exclusively verbally, based on verbal communication, and there's not much training or knowledge out there about how you would facilitate this with somebody who communicated non-verbally. But suicidal ideation can still be present even if not communicated verbally. So our subcommittee is wrestling with that question. I don't think we've come up with a solution that's we can share yet. But Leah, anything to add?
Yeah, no, I mean, they're definitely looking at it.
Yeah.
Okay, thanks for staying on and answering questions, and thank you participants for staying on. We really appreciate having you guys today. Thank you so much, Kara and Leah. And we have put the link for the next webinar, and we just want to say thanks and have a great day, and we'll see you guys soon.
Thank you so much.
Thanks.
Thanks.